Hello and welcome. My name is Melissa Carlson, and I have shared a short summary of my professional background at the end of these slides. The title of my presentation today is Introduction to Medication Safety. This is the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be addressed during this presentation. These are the key abbreviations that will be used during this presentation. Let's begin with a self-assessment question. A pharmacy stocks two different pre-mixed drug products, drug A and drug B. Both products are in 100 ml bags, they're packaged in aluminum overwrap, and they're stored next to each other on the shelf. Drug A is administered to a patient instead of drug B, the drug that was prescribed. What type of failure is present due to the lookalike products? Is it A, an active failure, B, a latent failure, C, a drug information failure, or D, no failure is present? We'll return to this assessment question later in the presentation, and I'll provide the answer and discuss the rationale. So let's start back at the beginning. To Err is Human was published by the Institute of Medicine way back in 1999, and they reported that as many as 98,000 people die in any given year from medical errors that occur in hospitals. The world was shocked. That's more than died from motor vehicle accidents, breast cancer, or even AIDS at that time, which were three causes that received far more public attention. To put this number in perspective, that's like a 747 full of people crashing each and every day in the United States. Imagine the uproar if that was happening today. People would be upset. They would be demanding change. Yet back then, no one was talking about medical errors at all. This publication just shattered the silence that had surrounded medical errors, and that includes medication errors, and brought the issue to the attention of the public and to healthcare systems. It highlighted why safety needs to be a priority for every healthcare organization across the country, and it spurred an increase in patient safety research. It finally had organizations asking the question, how can we learn from our mistakes? The main takeaways from the report are that, first of all, human beings are imperfect. We all come to work intending to do our best and to do the right thing, but even the best and the brightest of us make mistakes. We are not infallible. Errors are common in healthcare. 98,000 people die in any given year. And that doesn't even count all of the errors that happen that don't cause harm. Errors are costly. We know that adverse events cost our healthcare money. And when we have errors and we have to remake things, redo processes, people end up staying in the hospital longer, for example, that's money that is part of our overall healthcare costs. Errors are often related to system failures, so problems with the system. And then errors can be prevented. So if we can make our system stronger, then we should be able to prevent a certain number of errors. To Err is Human was followed by many other publications that in turn supported this broad notion that errors and harm in healthcare are prevalent, and they remain so. So while improvements in patient safety, again, which includes med safety, have been made, progress has been slower than most of us would like. Let's put that into context specifically for medication errors. The use of medications we know is extremely common. 1/2 of Americans take a prescription medication regularly, and almost 1/4 of Americans take 3 or more prescription medications regularly. When you think about the fact that errors can occur with any of these medications or, in acute care settings when more, short-term medications are being added, and they can happen at any point in the medication use process from procuring to storage to patient admission to prescribing to preparing to dispensing, administering, monitoring, and even up through patient discharge, and that errors can happen in any care setting. So not just acute care settings, but community settings, um, long-term care settings, etc. And even at home, the frequency of medication errors and preventable medication-related injuries presents a very serious cause for concern. There's a need for us as healthcare professionals to continue to focus on reduction of harm related to medications. Let's look at some of the data surrounding the frequency of medication errors. Published medication error rates depend on the specifics of the error detection methods used, so there is some variation in the published literature. This particular study looked at a random sample of 36 institutions, and in this case it was a mix of both hospitals and skilled nursing facilities. And using direct observation verified by a research pharmacist, they found overall that 19% of the doses administered were in error. That's nearly 1 out of every 5 doses. Although there were variations by site and region, there were no significant differences noted in the observed error rates between the settings or between the institution's sizes. The most common error types that were observed were wrong time, omissions, and wrong doses. 7% of the errors that they identified were judged to be clinically significant potential adverse drug events by a panel of physicians, and that percentage actually rose to 10% if the wrong time errors were excluded. So to put that into perspective, in a hospital with 300 patients, if we assume 10 doses per patient per day, that would translate into almost 40 potential adverse drug events per day. Some examples of the types of clinically significant potential adverse drug events that were detected included things like an anti-diabetic agent given with a low glucose level despite written hold parameters, or warfarin ordered but not given to a patient, or valproic acid given without an order, or the wrong formulation of insulin given, or a 2-time higher dose of an antihypertensive medication that was given. So you can see that, these are definitely things that could cause harm to patients. Let's consider the frequency of errors with IV admixtures. I think it's interesting to look at these products as a subset since these are among our most complex medications to prepare, to dispense, and administer, and they also tend to be higher risk medications. This study measured the rate of errors in IV admixture compounding at 5 different hospitals. And the study focused on patient-specific IVs, such as small volume and large volume injectables, ready-to-use IV solutions, anti-neoplastic formulations, and parenteral nutrition solutions. They found that the mean error rate for the 5 hospitals combined was 9%, and that excluded ready-to-use products. They found that wrong dose errors were the most common type detected, and that represented 69% of the errors. Parenteral nutrition solutions had the highest error rate out of all the product types, and that accounted for 26%. And ready-to-use products were evaluated at 2 of the study hospitals, and the error rate for the ready-to-use products was less than 1%. So that's really a strong argument for using pre-made products when they're available. One possible contributing factor to the errors that was noted by the researchers was the low light levels that were present in the inspection areas of the sterile compounding areas at all 5 hospitals. And then other things that they noted in their review included that a pharmacist was accessible to the technicians, but not always in the IV room itself. So that could have contributed. And there were many problems noted in the observations with aseptic technique, including backwash and touch contamination. So how does this translate to patient harm? Well, overall, the rate of potentially clinically important errors was deemed to be 2%. And while that may sound low, just remember, these errors involve drugs with narrow therapeutic ranges like aminoglycosides, anti-neoplastic agents, and related drugs. They involved components of parenteral nutrition solutions. Heparin was also one of the top drugs, as well as iron dextran. And then there was also this one instance in which the person preparing the solution actually stuck their finger with a needle and continued to prepare the IV solution without changing the needle. So that certainly could be a bad exposure for a patient. So we've been talking a lot about errors in healthcare facilities, but what about in community pharmacies? Let's look at a couple studies there. A large observational study measured the dispensing accuracy rates in 50 chain, independent, and health system pharmacies that were located in 6 different cities across the United States. And their main outcome measure was dispensing errors on new and refill prescriptions. They found an overall dispensing error rate of 1.3%. And it was interesting to note that the accuracy rates didn't differ significantly by the pharmacy type or by the city. Of the 77 identified errors, 6.5% of those were judged to be clinically important. So their conclusion was that dispensing errors are a problem on a national level. And they estimated a rate of about 4 errors per day in a pharmacy that fills 250 prescriptions daily. And if you extrapolate that over the course of a year, that could be an estimated 51.5 million errors each year. The second study evaluated the dispensing accuracy and patient counseling rates provided in community chain pharmacies in large metropolitan areas of Florida, Georgia, New Jersey, and New York. In this case, they used trained secret shoppers that presented a new prescription for one of 5 study drugs to each randomly selected pharmacy. And all of the encounters with pharmacy staff were recorded on video by ABC News 2020 staff using hidden cameras. Dispensing errors on prescriptions for the selected medications were an indicator of prescription dispensing accuracy. And the frequency of verbal counseling and information categories discussed or included in written information were used to assess the quality of the counseling. In this study, they found that for every 100 prescriptions dispensed, 22 had one or more deviations from the physician's written order. 3 of the errors were judged to be potentially harmful when dispensed to a typical patient requiring those therapies, and a total of 43 of the secret shoppers received verbal counseling, including 16 cases in which the shopper themselves prompted the counseling. So that was a rate of only 43%. So community pharmacies are not exempt from medication errors occurring either. Lastly, let's take a look at the number of emergency department visits that can be attributed to harm from medications. This study, using public health surveillance data from 2017 to 2019, attempted to characterize emergency department visits for acute harm from both therapeutic and non-therapeutic medication use in the United States. Overall, they looked at 96,925 cases and determined that there were 6.1 emergency department visits per 1,000 individuals annually that could be attributed to harm from medications. Of those, 38.6 resulted in hospitalization. Not surprisingly, older adults experienced the highest hospitalization rates. The medications that were most commonly implicated included anticoagulants, antibiotics, benzodiazepines, and that was for non-therapeutic use, and diabetes agents. So now that we've established that medication errors happen often and can result in harm to patients, let's consider how medication errors occur. Generally, medication errors are the result of failures in our medication use processes and/or the result of human factors. In other words, they're multifactorial. In healthcare, we work within very complex systems every single day, and the practice of medicine requires participation and assessment by human beings. And like I mentioned earlier, we are never infallible. So errors often occur due to things like lack of knowledge or slips and memory lapses, problems with identity checking, making our systems too complex, failure to standardize, or violations of rules. And then there's other factors that can, lead to error, such as different environmental issues, stress, communication problems, or interruptions. Let's talk in more detail about those failures. On the right is a depiction of the Swiss cheese model. This model was developed by Dr. James Reason, and he's a psychologist that studied safety events in aviation. This model explains how human error can line up with system problems resulting in events of harm. In most everything we do in healthcare, there are checks and barriers. Errors can arise for two reasons. We can have active failures and latent failures. Nearly all adverse events involve a combination of these two sets of factors. Active failures are human errors, things like lapses, slips, mistakes, rule violations, or confirmation bias. These are represented by the red arrow in the diagram. An example of an active failure might be a lapse where maybe I intend to place an order for an antibiotic for a patient with sepsis, but I get distracted by something else going on. Maybe I get a call to another area for something urgent, and then I forget to do that, resulting in an omission of therapy. Another example would be a slip, where maybe I intend to recommend 1,500 milligrams of vancomycin in my note, but I accidentally have a typo and end up recommending 2,500 milligrams. As human beings, we make these kind of errors all the time. To combat human error, we design barriers within our systems to help catch those human errors and prevent them from resulting in events of harm. These barriers can be technology, such as things like barcode scanning, or alerts in our computer system. They can be people or processes, such as, utilizing a double check or having a timeout, for example. And the slices of Swiss cheese in the diagram represent those barriers, those defenses that are put into place to help us catch those active human errors. However, no system is ever perfect. In an ideal world, each defensive layer would be fully intact, but that's just not the case in reality. So the holes in the Swiss cheese represent weaknesses in our defenses, and these are also known as latent failures. These are those less apparent failures of the organization or of design that contribute to errors. They're the failures in the design of the system, and they're much harder to see. And again, these can be things like management decisions, inadequate policies, heavy workload, staffing issues, or other less apparent design flaws. One example of a recent latent failure that we uncovered in our health system was related to a naloxone vial that we were buying. So one manufacturer had gone out of business and that put stress on the market, and we ended up having to buy from a new manufacturer. So when these new vials came in, they were placed in our ADCs and in our anesthesia machines, per our usual refill procedures. But what wasn't realized immediately was that these new naloxone vials had this kind of light aqua colored top, which was the exact same color as our current fentanyl vials that we had in stock. And fentanyl at that time was also on shortage, so we didn't have a lot of choices of manufacturer for that either. And looking further, these vials were actually the exact same size. They both had, similar size, small writing on the label. So there wasn't a lot to differentiate these visually from each other. And since these were both stocked in the OR near each other, and one, is the reversal agent for the other one, that could have easily resulted in an error. Luckily, this risk was discovered and somebody spoke up, thought this just doesn't seem right, and escalated that concern prior to anything happening. And we were able to quickly change to a different naloxone manufacturer so that the vials would look more different. Of course, you're always hoping that people are going to read, or that there's going to be a barcode scan that happens, or other ways, to prevent an error. But, these risks remain, that a human error could happen, and you want to be sure to have, as many checks and balances as possible. Should be noted that the presence of these holes, or these failures, or design flaws, whatever you want to call them, in any one slice of cheese doesn't normally cause a bad outcome. Most of the time we're really lucky, and these active failures are stopped by one of the layers of our defenses. But bad outcomes happen when all of those many layers of cheese and all of the holes line up momentarily to permit that error, making it all the way through our defenses, all the way to the patient where it can cause harm. And on average, safety events caused by errors are the result of 8.3 human errors that all lined up. All of those barriers failed. So this is really the key point. Errors are inevitable because human beings are infallible. And our lessons lie in the analysis of how our systems failed, implementing improvements, and being proactive for future prevention. James Reason said that we cannot change the human condition, but we can change the conditions under which humans work. So let's look at how we can reduce risk and enhance safety. Organizations should spend time prospectively designing and implementing strategies to reduce certain types of errors and to prevent patient harm. And the areas that we really need to look at and address are high-risk populations, high-risk processes, high alert medications, and easily confused drug names, for example. Proactive risk assessment tools, published policy or best practice guidelines, or other published strategies supported by evidence should be used to identify improvement opportunities. And when creating action plans, we should be choosing strong actions whenever possible, and our actions should be directed at multiple steps in the medication use process. The ASHP guidelines on preventing medication errors in hospitals lay out 3 principles for improved safety, and we'll take a look at each one of these. Principle 1 is to eliminate the chance of error. This calls for designing the system or the process in such a way that it's very difficult, if not impossible, to make an error. And good examples of this are using forcing functions or hard stops. Maybe there's a hard stop in your computer system if an anaphylactic drug allergy is detected for the medication that's being entered. Or, using syringes with unique connectors to minimize the chance of a wrong route error, such as ENFit syringes for the enteral route, and those, can't be connected to an IV line. Another example would be removal of a high-risk medication from floor stock, such as concentrated potassium, and that makes it, unavailable on the floor for compounding or for somebody to accidentally grab instead of another similar size or similarly looking bottle. And then only pharmacy can dispense that, risky drug under controlled circumstances. Lastly, using commercially available products instead of compounding is another strategy. And, this completely removes any risk of error that is specific to those compounding steps. Principle 2 is to make errors visible. This means using tools or setting up our processes such that when an error does occur, there's a really high likelihood that it will be caught before it causes harm. Think of some things outside of pharmacy that help us with this. Things like wet floor signs in front of the puddle to prevent people from slipping and falling, or barricades with blinking lights in areas where roadwork is happening so that we don't enter that zone. Barcode scanning technology is a really good example of making errors more visible in healthcare, because obviously if we've got the wrong thing in our hand and we scan it, that's going to alert us to that fact. We can also do this by use of best practice alerts. Of course, you want to be judicial with that, using checklists or using other types of alarms to alert us when something isn't right. Principle 3 is to minimize the consequences of errors. This means thinking ahead to mitigate the effect to the patient if an error does make it past all of our defenses. In other words, all of those layers of Swiss cheese. One way to do this specifically for medication errors is to think about how we can limit exposure to the medication. Using things like unit dose dispensing instead of, dispensing bulk bottles, or using the smallest possible vial or ampule size, or reducing the bag size of an IV infusion that you're dispensing, or reducing the concentration of a drug. Another example would be to implement monitoring protocols that would pick up quickly on any concerns with the therapy following administration and allow for fast mitigation of adverse events. An example of this would be, requiring capnography for post-op patients that received opioids. The ASHP guidelines also offer information on best practices related to each step in the medication use process. So let's start with procurement, which of course involves selecting which medications will be stocked and then safely obtaining the medications from manufacturers or wholesalers. So best practices for formulary assessment and management include limiting the selection of medications so that clinicians can more easily become proficient with the dosing, the preparation, and the administration of those meds. And also it provides less choices, which can streamline the content of the electronic health record and other technologies such as pump libraries. Formularies, when they're executed well, also ensure thorough review and vetting of the medication for efficacy and safety issues. And when medications with identified safety concerns are added to the formulary, it allows us to proactively identify mitigation steps that should be undertaken. Standard concentrations are recommended. Those can prevent errors, reduce waste, streamline inventory, and facilitate the use of pre-made infusions. Pharmacies should also have a strategy for safety alert monitoring so that as new warnings come out related to medications, they can be quickly acted upon. Warnings may come through the Institute for Safe Medication Practices, also known as ISMP, the FDA, National Alert Network, also known as NON, or other organizations. Safe procurement best practices include the pharmacy being responsible for all medications, even in procedural or imaging areas, and the pharmacy coordinating any outsourcing services related to medications. Organizations should also have strong and clear policies on the handling of samples or patients' own medications, and pharmacists should be involved in evaluating all medication devices used in the organization. With regard to medication shortages, the pharmacy should definitely take a lead role in developing and communicating plans for medication shortages, and that includes assessing alternatives for safety concerns and then again proactively implementing any mitigation strategies for any identified safety risks. With respect to medication storage, pharmacies should be thoughtful about product arrangement in the pharmacy and take steps to minimize mix-ups. Um, use things like barcode scanning, separation or segregation tactics for products that could be confused. Use special labeling when that's indicated. Pharmacies should also limit the stock that's available outside of the pharmacy, such as whatever is floor stock up on patient care units, and that will help reduce errors. We should also be thinking about using consistent drug nomenclature between labels and what's written or entered into the electronic systems so that it's easy to tell if things are matching up. Stock should be rotated to prevent expired medications from being available. And technology such as automated dispensing cabinets should be implemented where it makes sense because that allows for quick and easy yet controlled access to medications after pharmacist verification. Transitions of care are an area of high risk for medication errors. So even though pharmacists and pharmacy personnel are not solely responsible for this activity, it's recommended that pharmacy personnel should take shared accountability for medication histories and for the reconciliation processes, as well as for patient education and counseling. So moving on to prescribing. We know that common ordering errors include omissions, incomplete and unclear orders, wrong drug, wrong time, wrong dose, wrong dosage form, patient allergies, and wrong patient. And there's so many factors that providers need to consider when they're ordering medications. One single error could result in an adverse drug event. So best practices for prescribing include things like requiring complete information for medication orders, ensuring that the intent or indication for the medication is clear, using only approved abbreviations and nomenclature, making sure that we're using standard prescribing units, and making sure that we're using weight-based dosing for pediatric patients. We should be avoiding range orders and therapeutic duplication. We should be maximizing the use of CPOE while minimizing verbal and telephonic orders, and then developing and using standard protocols, pathways, or order sets. So moving on to preparing medications. We know that common preparation errors include wrong concentration, wrong drug, wrong dose, wrong diluent, wrong volume, wrong patient, and wrong route. So some things that we should be considering are first, that we need to make sure that we're providing adequate compounding training. And that doesn't just mean pharmacy personnel. It would also include any individual outside of the pharmacy that may ever need to compound a product. And, talking about compounding outside of the pharmacy, of course, we want to make sure that we're minimizing the need for that whenever possible. And we want to make sure that we're following all of the proper conditions and procedures related to preparing products, USP 797, for example. We want to be utilizing tools like barcode scanning to make sure that we have those double checks in place and implementing independent double checks by pharmacists for products. That includes verification of what ingredients are being used, the actual quantities of each individual item that's being used, not using the pullback method, and then making sure that we're checking expiration dates of all components. Whenever possible, we also want to make sure that we're providing medications in unit of use or ready to administer forms to prevent the need for any manipulation by the person that needs to administer that medication. And as we've mentioned earlier in the presentation, utilizing the correct type of syringe for the intended route so that we can avoid those wrong route errors. With respect to dispensing safety, all medications in non-emergency situations should be reviewed by a pharmacist or by an advanced pharmacy technician if we're in a tech check tech scenario. We should also be considering selective use of independent double checks as a safeguard for high-risk medications. I will note that literature on independent double checks is mixed, but it is a good strategy if it's used sparingly and thoughtfully. Hospitals utilizing automated dispensing cabinets should also be looking at minimizing the number of medications available to override prior to pharmacist review, to only those that really would be needed emergently. So moving on to administration. Nurses and other clinicians that are administering medications frequently are taught the 5 rights of administration: right patient, right drug, right dose, right route, and right time. However, this practice still leaves room for human error. So we have to think about, effective ways to further safeguard the administration process. And those are things like using those, syringes that have unique connectors for different routes of administration. Again, selectively using this idea of an independent double check for high risk medications. And we have to make sure that that's being performed in the way that it's intended as an independent double check. We also, again, want to be thinking about barcode assisted medication administration, use of smart infusion pumps, and providing easy access to medication information. So that brings us to monitoring. Monitoring errors may include failure to monitor at all, incorrect interpretations of the values, incorrect transcription or communication of the monitoring parameter, or incorrect timing. And so ways that we can combat monitoring errors include things like using standard monitoring protocols or pathways, using alerts and orders for specific timing of labs or other actions, and creating standardized documentation processes. The good news is that with concerted effort, we can reduce the incidence of medication errors. So let's talk about a few examples of some successful interventions. So first, let's look at how the use of barcode technology has impacted medication errors. This particular observational study was conducted at a large tertiary medical center, and they actually observed 6,723 medication administrations on patient care units that did not utilize barcode scanning, and then they observed 7,318 medication administrations on patient care units that did use barcode scanning. And they found that barcode scanning at administration did substantially reduce the rate of medication errors. They measured an 11.5 error rate without barcode scanning at bedside versus a 6.8% error rate with barcode scanning. So that was a 41% relative reduction. They also found that the rate of potential adverse drug events, other than those associated with timing errors, decreased from 3.1% without the use of barcode scanning to 1.6% with its use. And so that was about a 50% relative reduction. So that's good news. Computerized provider order entry systems is another great example of a success story. The implementation of CPOE systems resulted in dramatic improvements in medication error rates. In a meta-analysis of 10 published studies, the researchers were working to establish a baseline national estimate of medication errors that were averted in hospitals due to the use of CPOE. And they found that there was a 48% reduction noted in the likelihood of a prescribing error in hospitals that were using CPOE as compared with historic paper-based ordering systems. This was really the first study that attempted to establish this type of a national estimate related to CPOE use, and the authors went on to project a reduction in medication errors by 17.4 million per year due to the use of CPOE. While this does represent an important indicator of potential gains as health IT systems are expanded and more deeply integrated in care delivery systems nationwide, we do need to recognize that there can always be unintended consequences to new technology as well, and make sure that we're prepared for that and studying the effects of that as well. Lastly, we have seen errors decrease as a result of IV workflow systems. So this particular study looked at an IV workflow system that included gravimetrics, and this also resulted in a reduction in medication errors. So in this study, 15,843 doses were prepared utilizing this IV workflow system that incorporated both barcode scanning and gravimetrics. And they found that there was a 74-fold increase in the detection of errors during compounding, which could then be corrected prior to the dose leaving the pharmacy. This certainly improved the accuracy of the IV sterile compounded products leaving the pharmacy and potentially improved patient safety due to the increased detection of preparation errors. And this is a really good example of making errors more visible. So now that we have reviewed the data surrounding medication errors, how and why medication errors happen, and discussed best practices to reduce the likelihood of medication errors, let's go back to our self-assessment question from the beginning of the presentation. A pharmacy stocks two different pre-mixed drug products, drug A and drug B. Both products are in 100 ml bags, they're packaged in aluminum overwrap, and are stored next to each other on the shelf. Drug A is administered to a patient instead of drug B, the drug that was prescribed. What type of failure is present due to the lookalike products? A, active failure, B, latent failure, C, drug information failure, or D, no failure is present. If you answered B, latent failure, you are correct. Lookalike products stored near each other on the shelf are a latent failure because this is a less apparent failure within the design or layout of the pharmacy, and it's possibly even a poor management decision with regard to which products to stock. An active failure is an incorrect answer because we're really focusing on the presence of the lookalike products here, not the human action or interaction with the system. Drug information failure is incorrect because there really was no evidence provided in the question of a lack of information about the products. And then no failure present is also incorrect because there was a lookalike product there presenting a risk, and the wrong drug was indeed given to the patient. So to wrap up our time together today, I would like to leave you with just a few takeaways. First, the patient safety movement over the past 20 years has contributed to significant improvements in medication safety. And that's great, but we can't rest because important safety issues remain. Medication errors are often multifactorial and the result of failures of complex interacting clinical systems. Latent system failures are often overlooked. Yet identification and due consideration is critical to development of effective error prevention strategies. We need to continue to be vigilant. Organizations should prospectively design and implement strategies to reduce medication errors to prevent patient harm. The upcoming modules will help you gain knowledge and skills to do just that. These are the references used to develop this presentation. Thank you so much for your time and participation.